Okay, a patient started on lisinopril, returns with swollen lips and tongue. What action is priority? Administer PRN cough suppressant, elevate the head of bed and continue drug, discontinue the drug and notify the provider immediately, reassure the patient that this is expected. A patient started on lisinopril with a swollen tongue and lips. That's anaphylaxis. That's bad. So we're going to C, discontinue the drug and notify the provider immediately. 3, the nurse teaches the 5 rights of medication administration. Which should the nurse include? Select all that apply. A, right patient. B, right drug. C, right brand name. D, right dose. E, right time. A, B, D, and E. Right brand name is not in there. 4, a malnourished patient with low albumin is prescribed a high-protein bound drug. What outcome is most likely? A, decreased free drug and reduced effects. B, increased free drug and potential toxicity. C, no change in the drug response. D, increased binding and reduced absorption. It's B, increased free drug and potential toxicity, because you have low albumin with protein, they're going to fight each other, and it goes into your plasma, and you might die or might get sick. A pregnant patient asks why some medicines aren't recommended. The best response is A, all drugs are harmful in pregnancy. B, some drugs can cause birth defects. C, medications are always safe after the first trimester. D, pregnant patients must avoid all medication. I hope you guys get this because this was just dumb. It's B, some drugs can cause birth defects. 6, a patient on warfarin begins taking daily aspirin for daily headaches. I read that wrong. Which effect is most concerning? Reduced therapeutic effect. B, increased bleeding. C, reduced aspirin absorption. Or D, increased protein binding of warfarin. You're mixing 2 blood thinners together. B, increased bleeding risk. 7, the nurse provides discharge teaching for oral morphine. Which statement indicates a further need for teaching? I will drink water and eat fiber to prevent constipation. B, I will use a stool softener if needed. C, if my pain improves, I can stop this medication suddenly. D, I will avoid driving until I know how it affects me. Which statement indicates a further need for teaching? C, if my pain improves, I can stop the medicine suddenly, because you cannot just, you're gonna get withdrawal. It's morphine. Which drug-food interaction requires intervention? Grapefruit with a calcium channel blocker? These questions suck. Milk with acetaminophen, orange juice with ferrous sulfate, or cranberry juice with vitamin C. Grapefruit juice with a calcium channel blocker. It doesn't affect all medicine. It does not affect benzos. It does not affect opioids, but grapefruit does affect some things. One of those things is a calcium channel blocker. Which finding is a predictable side effect rather than a drug allergy? Urticarial rash after penicillin, that's hives. Constipation while taking opioids. Angioedema after an ACE inhibitor. Anaphylaxis after contrast dye. Constipation while taking opioids is a side effect of opioids. Secondary question, if you are constipated, what are the steps of trying to get yourself to poop if you're taking morphine? I'll give you a second to answer. That's right. You're going to change your diet. You're going to increase your fluid, increase your fiber. Then if that doesn't work, you're going to take a stool softener or a laxative. If that doesn't work, they're going to give you a very specific medicine. It has a name. I actually have it written down somewhere. Methanoltrexone, which stops the mu receptors only in your GI tract. It does not cross the blood-brain barrier. 10. A patient receiving IV vancomycin develops flushing and erythema, which is superficial reddening of the skin, of the face and upper torso during the infusion. What is the priority action? A. Stop the infusion. This is anaphylaxis. B. Slow the infusion and monitor closely. C. Give IM instead of IV. D. Continue the infusion, benign reaction. Okay, the answer is B. Slow the infusion and monitor closely. I don't know if we really went into this, but this is a patient receiving IV vancomycin. They are flushing and they're turning red. This is red man syndrome. We learned this in patho. It's just they turn red. This is one of those things where you can eliminate all the other questions. Stop the infusion. This is anaphylaxis. This is not. That requires swelling of the face, swelling of the tongue, really kind of like a respiratory issue. Give IM instead of IV. That does nothing because, I mean, maybe it would in some imaginary world where it has to go because it's going through absorption. Maybe it would go differently, but it's just, no, that's not the answer. Continue the infusion, benign reaction. That's going to be the answer, never. A nurse is preparing to administer an oral drug in a patient seen with severe nausea and vomiting. Which principle applies? Oral route ensures the fastest onset. Consider alternative routes due to impaired absorption. Increase the dose to overcome vomiting. Give with food to avoid emesis, which is vomiting, regardless of absorption. The answer is consider alternative routes due to impaired absorption. You cannot give something by mouth to somebody who's throwing up because they're just going to throw it up. That doesn't make sense. And you could figure that one out too from this question. Oral route is the fastest. It's not. Increase the dose to overcome vomiting. Because what if they don't vomit it up and you give them triple the dose or double the dose, then they die. Give with food to avoid emesis. When have you ever been throwing up and then been like, I'm going to eat a bunch of food? 12. A nurse caring for an older adult starting a benzodiazepine expects which change in dosing? Higher dose due to faster metabolism. Lower dose due to increased sensitivity. Same dose as a young adult. Loading doses recommended to achieve effect. Lower dose due to increased sensitivity. Older adults, your shit's not working the same. Your liver's not working the same. Your kidneys aren't working the same, so they have to give you a lower dose. You're more affected by stuff that you would have not been when you were younger. Okay, this one. Oh, I just got a notification that scared the shit out of me. Oh my god. Which best describes pharmacocytokines? What drugs do to the body? The study of drug movement in the body. The study of receptor-drug interaction defects, or the clinical testing of a new drug. Pharmacocytokines. The study of drug movement in the body. B. And what are those things? Secondary question. I'll give you a second to answer. Yes, you're right. Absorption, distribution, metabolism, excretion. What is absorption? Yes. From the administration site to the blood. What is distribution? Yes. From the blood to the site of action. What is metabolism? Yes. From the site of action to the liver. What is excretion? Yes. From the liver to the kidneys, and then how do you excrete it? That's right. You poop it out or you pee it out. A lot of the times you pee it out. Okay, a patient asks why transdermal fentanyl, this is the one we haven't done at all. A patient asks why transdermal fentanyl cannot be used for acute postoperative pain in an opioid-naive adult. The best response is, it is not potent enough for surgical pain. The patch may cause delayed, prolonged respiratory distress in opiate-naive patients. The patch is for migraines only. It causes less analgesia than acetaminophen. Okay, that one was a little rough. The answer is B. The patch may cause delayed, prolonged respiratory distress in opiate-naive patients. Transdermal fentanyl is only, it's really kind of just exclusively for cancer patients who are who have a tolerance to opioids already. You can't use it in anyone else because you're just gonna die. Okay, the 15. The provider provides naloxone for a patient with pinpoint pupils and shallow respirations after receiving opioids. Which outcome is expected? Reversal of CNS or respiratory depression, enhanced analgesia, no change if opioid is present, or D, both A and C, which were reversal of CNS and respiratory depression, or why is that changing colors? Oh shit, I forgot you can see my I forgot you can see my computer. What am I doing all this for? Okay. Reversal of respiratory depression, no change if opioid is present. Your answer is both A and C. Because if you give naloxone to somebody who doesn't have an opioid, then nothing's going to happen. If you give it to somebody who does have an opioid, it's going to stop. If you give naloxone and an opioid at the same time, you are not going to have any, there will be no effect of the opioid. Okay, which instruction is essential for a patient receiving patient-controlled analgesia, a PCA, with morphine? That's the little machine, that's the button. Okay, family should press the button if you are sleeping. Only you should press the CPA button. Expect a large bolus every 3 hours. Do not report drowsiness. So, B, clearly. The biggest thing, how you go through all these, your family shouldn't press your button. If you're sleeping and they're like, oh, they look like they're in pain, don't press it. I mean, that's just common sense. Large bolus every 3 hours. The entire point of this thing is it is one continuous way of dosing an opioid. So rather than getting, 5 milligrams or 20, let's say 20 milligrams of whatever over every 3 hours, you're going to get 1 milligram every 10 minutes. And then do not report drowsiness. I'm pretty sure opioids, one of their symptoms is sedation, so I'm not really sure why, but I mean, clearly it's this answer. I mean, I can look at it and see if that's the right answer. What are we on, 16? What's the rationale? Yeah, no, I don't know. Incorrect education, apparently, is... Oh, I see. I see why that's wrong. I'm just dumb. Do not report drowsiness, but yeah, they're gonna say report drowsiness or, because that will keep someone from whatever. A patient is taking a benzodiazepine, asked about risks with alcohol use. The best response is A, alcohol reduces the effect of benzodiazepines. Combined use can cause severe respiratory depression, coma, or death. Alcohol prevents tolerance. There is no interaction. Okay, guess what the answer is? It's combined use can cause severe respiratory depression, coma, or death. I guess it does reduce no, it doesn't reduce the effect, because if you take it with alcohol, you've ever heard of someone in high school? Okay, well, I don't know what kind of high school you guys went to, but people in my high school would take like a school bus and then go get drunk, and it was like it was a good time. So that's why you don't do that. Patient receiving morphine develops urinary retention. Which mechanism contributes to this effect? Decreased detrusor muscle tone and sphincter relaxation, increased bladder sphincter tone and impaired bladder awareness, increased diuresis from ADH inhibition, or direct nephrotoxicity. This is your answer. It messes with your tone. It messes with your muscle tone. It messes with your GI tract. Think about you're constipated. It stops all of those propulsions and those like muscle squeeze. Basically, like if you had a Go-Gurt and you squeeze the bottom of the Go-Gurt, all of it would shoot out the top. That's basically what your GI tract does when it's making poop. So same thing. Opioids decrease muscle tone, or decrease movement, and it makes things more rigid. So that's the answer. I don't know why these other two. I don't even know what that means. A nurse is teaching about partial agonists, such as, or also known as agonist antagonists, such as buprenorphine. Buprenorphine. Which statement is correct? They have no intrinsic activity. They can precipitate withdrawal in patients on a full agonist. They always produce a stronger analgesical effect than full agonists. They are ineffective for pain. I mean, these are more like, this one's more used for like, I don't know what the fuck it's used for. But the other partial agonists are used for like withdrawal symptoms and stuff. This one, the answer to this is it can precipitate a withdrawal patient or like thing in patients. So basically, precipitate withdrawal, it can cause withdrawal. If you take it with morphine and you take this, it is going to knock the morphine out of that receptor and put itself in there or block it, and you're going to start being like, oh my God, where'd the morphine go? So it's kind of like naloxone, but it still has its own effects. Okay, which patient should not receive the transdermal fentanyl patch? An adult taking long-acting morphine for months? No, this is the question. This is saying, do they have a tolerance? Opioid naive adult after dental procedure, cancer patient on scheduled opioids, or post-op patient with established tolerance. This is what this is saying. Does this person have a tolerance to, fentanyl or just really kind of any opioid? No. The person after the dental procedure, give them some I don't even know what they get, probably hydrocodone or something. No, you get Oxy when you go to the dentist. Okay. The nurse understands that a drug with a narrow therapeutic index requires. What? The nurse understands that a drug with a narrow therapeutic index requires less monitoring because it's safer, more monitoring because the toxic dose is close to the effective dose, no dose adjustments, PRN dosing only. Okay, let me make a little. Oh, that's a highlight. I can't mark this up. Okay, look at this. This is crazy. This is what the therapeutic range thing is. So you have this and this. This is toxic, and this is effective. Oh, give me my thing back. This is, oh my God, I hate this. This is like a narrow thing. So this is saying basically the space in between being effective and toxic is very, very small. So if you had somebody who was taking, of course I don't have an example, but a made up medicine that one pill is an effective dose, or one and a half pills is an effective dose. But if you were to take, 1 1/3 pill, or 75% rather than 50% of the pill, it'll kill you, right? And you have to cut this pill yourself. They don't make half doses. That is a very narrow therapeutic index. All it takes is you having a little pill cutter and moving the pill a little to the left, and now you have 75% of this pill, or let's say 55%. You have to be right on the mark of 50. That is very narrow. Okay, glad we got that out of the way. A patient takes tetracycline with a calcium-rich meal. What is the likely effect? Okay, tetracycline, whatever. I don't know what the hell this question is even asking. I don't know anything about this, but sure. Enhanced absorption and efficiency. That probably won't be the answer. Formation of insoluble complexes and decreased absorption. Increased distribution into bone, increased hepatic metabolism. So just going based off of these questions, I'm going to guess if you mix a tetracycline with calcium, they will interact in a way to form insoluble. They'll come together, they'll be insoluble, and your body's not going to have a good time because it can't use that medicine anymore. I actually remember this. So B, yes, formation of insoluble complexes and decreased absorption. Okay, we're almost halfway through. Which statement of a drug-drug interaction is accurate? Interactions always reduce therapeutic effects. Interactions can increase therapeutic effects or adverse effects. Interactions occur only with prescription drugs. Interactions are clinically insignificant. The nurse caring for a patient on morphine notes new confusion, Wait, no, what the fuck? I was just reading down the page. I actually don't even remember what I was doing. I was just thinking about something else. Okay, let me try again. Which statement about a drug-drug interaction is accurate? Interactions always reduce therapeutic effects. Interactions can increase therapeutic effects or adverse effects. Interactions occur only with prescription drugs. Interactions are clinically insignificant. I mean, let's just think about it. If you take a drug and you take two heparin, or you take a heparin and you take a aspirin, that's an adverse effect. If you take of course I can't think of anything in the world right now. If you take codeine that's mixed with acetaminophen, you have a higher pain limit. So therapeutic effect would be the hydrocodone or something, because that's mixed with acetaminophen or aspirin, and then adverse effect would be heparin and aspirin. Okay, a nurse caring for a patient on morphine notes new confusion, myoclonus, hyperglycemia after prolonged high doses. What does the nurse suspect? Opioid neurotoxicity, mild tolerance, placebo effect, or anxiety? Okay. Oh, I don't know. I wonder what the answer is. Okay, clearly it's opioid neurotoxicity. These are all, first of all, the patient's on morphine, so we know. Then we have really bad symptoms. Myoclonus. This is pretty sure that's like the low muscle tone. Yeah, oh, it's the jerky one. It's where I was kicking my legs up in our secret room. Hyperglycemia. Yes, I'm hyper aware of sensations. Okay, a patient with chronic pain on codeine reports poor pain control. Which factor may explain reduced effects? Codeine must be activated by metabolism. Codeine is a non-opioid. Codeine never works for moderate pain. Codeine is not orally effective. One of these things is not like the other. Codeine is an opioid. Codeine is literally an opioid and is for mild to moderate pain. No, it's for moderate to severe pain. Codeine is not orally effective. I don't know about you guys, but my friends used to like to partake in this activity that required two styrofoam cups and some Sprite. And they drank it, and it involves some codeine. So it is certainly orally effective. So why don't you know, wow, codeine must be activated by metabolism. Okay, I'm going to do half this.